Good morning, everyone. My name is Sarah Frasure, and I am an assistant professor of emergency medicine at George Washington University Hospital. Today, we're going to talk about abdominal ultrasound, including small bowel obstruction, appendicitis, and diverticulitis. The objectives of this lecture will include the identification of small bowel obstructions, appendicitis, and diverticulitis on ultrasound, demonstrating the proper ultrasound techniques, having you identify the relevant pathology when you're performing the examination, and being able to impress your peers with your excellent sonographic skills. So let's start with small bowel obstructions. Causes of small bowel obstructions include hernias, cancer, intussusception, volvulus, and adhesions. Symptoms of small bowel obstructions include nausea and vomiting, crampy abdominal pain that seems to come and go in waves. Some patients may also complain of back pain. Patients may have diarrhea or they may be constipated. And if a patient has had a small bowel obstruction in the past, they may say that this feels just like their prior SBO. So when I was a resident many moons ago and I was concerned that a patient had a small bowel obstruction, the surgical consult service would often ask for x-rays. An x-ray essentially has a sensitivity approaching somewhere between 40 and 50%, so you might as well toss a coin if you want to determine if the patient has a small bowel obstruction or not. The gold standard for diagnosing a small bowel obstruction is the CT scan, but I am hopefully going to be able to show you that ultrasound can be incredibly useful with both a high sensitivity and high specificity in terms of making the diagnosis of a small bowel obstruction, and that it's very easy to do. So the first journal article looking at ultrasound and small bowel obstructions was published in the American Journal of Radiology in 1979. 3 cases of patients who had a normal KUB, yet an ultrasound where the diagnosis of a small bowel obstruction was made. And the radiologists agreed that there were 2 specific characteristics. One was dilated fluid-filled structures, and the second characteristic was called back and forth peristalsis. So how do we perform this exam? Certainly you could use a phased array or a curvilinear probe, depending on what is available in the emergency department. You want to have a lot of ultrasound gel, and you want to walk across the abdomen, and you can do this in horizontal or vertical rows. You want to make sure that you get the right upper quadrant, left upper quadrant, as well as the right and left lower quadrants as well. It can be very hard for patients to localize the pain of a small bowel obstruction since it seems to come and go in waves, depending on where peristalsis is occurring. Unlike appendicitis or diverticulitis, where patients are able to point to the maximal area of tenderness. So it's incredibly important that you look everywhere if you're looking for a small bowel obstruction. So what are we looking for in ultrasound? Essentially what we're looking for is this dilated fluid-filled loop of bowel that's greater than 2.5 centimeters in diameter, and you're going to be measuring across the bowel like this. You're looking for back and forth peristalsis, and I'll show you a couple of video clips of what this looks like. But essentially you can imagine peristalsis occurring and then the bowel hitting an obstruction and peristalsing backwards. So this is the concept of back and forth peristalsis. And then you may see free fluid, and there are a couple small pockets of free fluid on this image, and that suggests microperforations and may also be indicative of a higher grade obstruction. So here's a nice video clip of normal bowel. Up here you can see abdominal wall musculature. And then here you're not really seeing a whole lot, and this is because the bowel is full of air. So you'll see lots of shadowing related to air, but you're not really seeing great images of the bowel itself. And this is because this is normal bowel without any evidence of a small bowel obstruction. So again, this is an image of a small bowel obstruction. And what you'll note are these very dilated, fluid-filled loops of bowel. Here you have one loop of bowel that has both fluid and solid fecal material, and then another loop of bowel, and again the same thing. Here you've got fluid-filled loop with solid material posteriorly, and you can also see the little plica circularis of the small bowel. Essentially what you'll do is measure from top to bottom of this loop of bowel, and if it's greater than 2.5 centimeters, it's certainly concerning for a small bowel obstruction. Here's a nice example of a small bowel obstruction, and again you would measure from top to bottom of the bowel. You can see some of the plica circularis here. And then you'll see this back and forth peristalsis where it looks like the matter, the fecal matter is moving in one direction, but then it seems to drift backwards again. And this is what back and forth or pendulous peristalsis looks like. Here's another nice example of two loops of bowel next to each other. And again, you can visualize this back and forth movement of the fecal matter within the loop of bowel. You can see that this loop of bowel right here has is mostly fluid filled, whereas this one mostly has solid material within it. But again, you're looking for not only the dilated fluid filled loops of bowel, which you can measure if you freeze the image, but also this back and forth movement of fecal material. Here's another nice example. Again, we have two fluid-filled structures or loops of bowel next to each other. And again, you're looking for pendulous peristalsis or back and forth peristalsis of the material within the loops of bowel. This is perhaps my favorite ultrasound video clip of all time. I call this the waterfall of poop. Again, very dilated, fluid-filled structures with some fecal material as well, and here we're not really even seeing any peristalsis at all. And this is what a CT scan looks like for a patient with a small bowel obstruction. So you can see that the image is actually pretty similar to that of an ultrasound, with these very characteristically dilated loops of bowel that contain both fluid as well as solid material. So let's talk briefly about the literature behind the use of ultrasound to make the diagnosis of a small bowel obstruction. We should note that the majority of these studies have actually been performed in Europe, Asia, and Africa, where ultrasound is actually much more prevalent than in the United States. In Europe, specifically, ultrasound is performed much more frequently than in America, not only to limit healthcare costs, but also to limit radiation. Most hospital wards have an ultrasound machine on every floor, which the residents and the attending physicians can use. And there are far fewer CT scanners in the hospitals across Europe. So looking at some of the American literature in particular in emergency medicine, this is a very nice study that was published in Emergency Medicine Journal in 2011, looking at bedside ultrasound to detect an SBO in emergency department patients. This was a prospective study. Individuals who helped to enroll patients, and this included residents and attending physicians, had a 10-minute training module and had to perform 5 ultrasound exams before they were able to start enrolling patients. All patients underwent both plain film imaging and a CT scan to look for a small bowel obstruction so that the authors of the study could examine and compare ultrasound to X-ray to CT scanning. So they enrolled 76 patients from the emergency department, and of those patients, 43% ended up being diagnosed with a small bowel obstruction on CT imaging. The rest of the patients had other pathologies such as kidney stones, diverticulitis, appendicitis, or pyelonephritis. Of the patients who had a CT scan that demonstrated a small bowel obstruction, Ultrasound had a sensitivity and specificity of 91 and 84%, compared to X-ray, which had a sensitivity of 46% and a specificity of 66%. So I think you can see here, just based on this very small study, that the sensitivity and specificity of ultrasound are much better than plain film imaging if you're concerned about a patient in the emergency department with a possible small bowel obstruction. So we actually looked at this a couple of years ago, and we wanted to know how accurate a point-of-care ultrasound would be for diagnosing small bowel obstructions in patients who also underwent CT imaging as the gold standard. We wanted to see if there was any difference in level of provider training, so whether you were an intern or a senior resident, a physician's assistant, an ultrasound fellow, or an ultrasound attending. Again, all patients underwent both a point-of-care ultrasound and a CT scan as the gold standard to look for a small bowel obstruction. So this is really the first study, to our knowledge, that included physician's assistants as ultrasound operators in the ED as well. So our sensitivity and specificity were 93.8 and 95.2%, which is very similar to prior studies. And so we decided that using a broad range of emergency providers, from intern to attending physicians, our results actually compare similarly to prior studies, suggesting that ultrasound can play a very important role in the identification of small bowel obstructions in ED patients. So now let's talk about appendicitis. Symptoms of appendicitis generally tend to include nausea, vomiting, this wandering abdominal pain from the epigastrium down to the right lower quadrant. Patients may have fevers or chills, often loss of appetite. Occasionally patients will have back pain more so than abdominal pain, and this may be due to an appendix that is located retrocecally. The most common pediatric condition requiring surgery is appendicitis, and the incidence is highest between the ages of 10 and 30 years. 1 in 15 people will get appendicitis, so we probably all know a couple of our friends or family members who have had appendicitis, if not ourselves. What's interesting is that there seems to be a bimodal distribution. So we initially have the incidence being very high between the ages of 10 and 30, and then for unclear reasons, patients in their 60s and 70s tend to have a higher incidence of appendicitis again. This is called a bimodal distribution. Causes of appendicitis include fecaliths, so when fecal material gets stuck in the appendix and causes inflammation. Certainly viruses and parasites can cause appendicitis. Tumors can occasionally cause appendicitis. Sometimes we'll have patients who have swallowed a foreign body, either intentionally or unintentionally, like a bead from a necklace or paper clip. Pins, for example, and those can get lodged in the appendix and lead to inflammation and appendicitis. And then patients who are chronic sufferers of constipation or fecal stasis tend to be at higher risk for appendicitis. So how do we perform this examination? Again, you can use any type of probe. The phased array or abdominal/curvilinear probes are probably your best bet. If you have a very thin patient, I may actually start with a linear probe and take a look first before I move on to the phased array or the abdominal probe. Again, you want to have copious ultrasound gel. You can have the patient cross their legs right over left, which relaxes the abdominal wall musculature, which can make it easier for you to identify the appendix. And you want to ask the patient to point to the area of maximal tenderness, and that's where I tend to start with this technique. So unlike small bowel obstruction, where you really want to do a complete abdominal examination and look everywhere in every quadrant, the appendicitis ultrasound usually is maintained in the right lower quadrant. So you generally don't have to move around very much, and patients can point to where it hurts the most. So this is, in the transverse view, the anatomy that you're looking for. Certainly up here you have your rectus muscles and then your internal and external obliques, which are off the picture, your very large psoas muscle. You'll see a little bit of the iliac crest posteriorly to the psoas muscle. And then in this area, you're going to find your iliac vessels, so the iliac artery and the iliac vein. Often the appendix will actually be draped over the iliac vessels, so you'll find it in this area. Sometimes it'll be between the muscle, the psoas muscle, and the vessels, and then occasionally you're going to actually find it posteriorly to the vessels, and this can be a more difficult or more challenging examination. So what are we looking for when we're trying to diagnose appendicitis? Well, there are a couple of characteristics that you want to look for if you are performing this examination. And these include the following. So we are looking for a non-compressible, blind-ending tubular structure. So if you're looking at something that you think may be the appendix and it is compressible, then that's unlikely going to be the appendix. Similarly, there should be no peristalsis. So if this tubular structure that you're looking at is peristalsing, then you have identified small bowel, but not the appendix. Generally, patients with appendicitis will have an appendix that's at least 6 millimeters, if not 6.5 to 7 millimeters in diameter. And what you're going to do is freeze the image and then measure from top to bottom across. Often you'll see appendiceal wall hyperemia if you put color flow on the appendix. You may see an appendiculith sitting inside the appendix. And then something that I think is not necessarily always talked about, but very important, is the idea of fat stranding or fat enhancement and or free fluid around the appendix. So the presence of hyperechoic fat or free fluid is very concerning for inflammation in that general area. So if you see fat stranding or fat enhancement, then you're looking in the right spot. So here are two nice images, one longitudinal and one transverse, of a patient with appendicitis. So remember that a longitudinal image means that the probe marker is pointing towards the patient's head, and you'll generally see the appendix looking like a pencil or a pen. And in the transverse view, where you have the probe marker pointed towards the patient's right side, you really get more of a bullseye appearance. So again, in the longitudinal view, you get this very nice kind of finger-like structure or pencil-like structure. And in the transverse view, you're really looking for a bullseye. And you can see some of the abdominal wall musculature on either side here. Now, what I want you to pay attention to is this fluffy white fat stranding that you can see around the appendix. So you see it in both the longitudinal and the transverse images. And this fluffiness, haziness, kind of bright white hyperechoic fat stranding is pathognomonic for an infection or inflammation in the abdomen. So it may be the result of an appendicitis, it may be the result of a diverticulitis, but what you see is that something is going on in this area. So you're training your eye to look for this fluffy, white, hazy fat, almost looks like a cellulitis if you think about it. And this is an area of infection. And again, just to really hone that point, here's an example of a normal appendix, and we don't see any of that fluffy white haziness. Here's an example of appendicitis. Again, these are both in the transverse view, and you can see this hazy white surrounding fat, indicative of an infection or inflammation in the area. All right. We're going to start with a nice video clip in the longitudinal view. Again, you see this finger-like structure coming into play below the rectus muscle. And what you're looking at, again, is a nice example of appendicitis with the surrounding white, hazy fat stranding. So you're training your eye not only to look for the appendix, but to look for the fat stranding, which is indicative of an inflammation or inflammatory infectious response in the area. And here's the same appendix. Now we're in the transverse view. Again, you've got musculature, abdominal wall musculature above. And as we look posteriorly, we see this bullseye appearance of a non-compressible structure that is not peristalsing, surrounded by some fat stranding or fat enhancement indicative of an infection. Now you can freeze this frame and you can measure the appendix from top to bottom and look to see whether it's greater than 6 millimeters in diameter. Here's another nice view. This is again a longitudinal view. So you're looking for this finger-like or pen-like structure that is non-compressible. There's no peristalsis. You can see that white hazy fat stranding around it. If you freeze the frame and measure it, I think that this one was about 10 millimeters in diameter. And here you can see a fecalith at the very end or the very tip of the appendix with some shadowing posteriorly. Here's another nice example. This is a longitudinal view with a curvilinear probe, looking at a very dilated appendix. I think this one was 12 millimeters in diameter, measured top to bottom. You can see that there's also a fecalith inside this one. And again, lots of hazy fat stranding around the appendix. This is your clue that there's an inflammatory / infectious response in the abdomen. Here's another nice example, again, a longitudinal view with the probe marker pointed towards the patient's head. This is using a curvilinear probe. And again, here's your non-compressible structure that is not peristalsing. This one was about 10 millimeters in diameter and also has an area within the appendix that probably is a fecalith sitting at the tip. Here's another nice view of an appendix. This is in the transverse view, so we have a curvilinear probe. The probe marker is pointed towards the patient's right side. And here you can see we're following the appendix down to the cecum. And again, we have a very dilated appendix. We have fecalith sitting inside the appendix with shadowing. And then again, look at all this white fat stranding or fat enhancement surrounding the appendix. This is a nice example of appendicitis. So let's talk about the literature using ultrasound and using ultrasound to diagnose appendicitis. So most of the literature looking at the use of POCUS or point of care ultrasound and appendicitis has been published in the pediatric literature. This is a really nice study that was published in Academic Emergency Medicine in 2014 by a group of pediatric emergency physicians in New York City. A prospective observational convenience sample looking at 150 pediatric patients who were enrolled in an urban emergency department with suspected appendicitis. So the exclusion criteria included any patient who walked into the ED who had already had the diagnosis made, either by ultrasound or CT that they brought with them, patients who were unstable and were thus not enrollable. This was a 30-minute training session, so a little bit more than the training session in the studies that we looked at for small bowel obstruction. And anybody could enroll, so you could have multiple different levels of providers from interns to attending physicians, but you had to attend the 30-minute training session prior to enrolling patients. And they were really looking at whether the use of point-of-care ultrasound could not only diagnose appendicitis, but whether this could reduce length of stay in the emergency department and reduce the number of CT scans performed in the emergency department to look for appendicitis. So the take-home points for this study were the following. Ultrasound certainly decreased length of stay when compared to CT imaging. If you could perform a point of care ultrasound and you could diagnose appendicitis and call the surgical team to assess the patient, these patients were much more likely to head to the operating room than patients who were waiting for a CT scan, which could take many more hours. The baseline CT rates decreased from 44% of patients getting a CT scan to 27% once they started the study, which is a big deal. And the short 30-minute training session was actually really effective. So residents were able to diagnose appendicitis after a short training module performed with an attending physician who was ultrasound fellowship trained. So certainly there were a couple of limitations to the study, which you can probably imagine. One of which, and a limitation that comes up with most of the point of care ultrasound studies, is that ultrasound is operator dependent. So what this means is that the more ultrasound scans that you perform, the better you get at making the correct diagnosis. So if you've only performed 2 ultrasounds to look for appendicitis, you're not going to be as agile or facile as somebody who's done 30 studies to look for appendicitis. And part of this is you have to train your eye to visualize the correct anatomy, and you have to know how to recognize the pathology on ultrasound. So the more that you do of any type of ultrasound, the better you're going to be. So that is probably the largest limitation that we can think of to this type of study. All right, so we're going to end our lecture today with one of the most exciting abdominal ultrasound scans and one of the newest techniques that we've been looking at, and this is using ultrasound to diagnose diverticulitis. So we see diverticulitis a lot in the emergency department. Approximately 130,000 individuals are hospitalized yearly with diverticulitis. Many, many more of those come to the emergency department, get a CT scan that demonstrates diverticulitis, and are well enough to go home and take oral antibiotics. Diverticulitis is a pretty common disease, and we perform a lot of CT scans. So wouldn't it be great if we could make this diagnosis using point-of-care ultrasound? We could reduce length of stay for patients in the emergency department. We could reduce CT imaging utilization, and thus cut our healthcare costs. So let's talk about the culprits. What causes diverticulitis? So certainly weakening of the bowel wall can cause diverticulitis. Irregular bowel contractions increase your risk of diverticulitis. A family history increases your risk. So if parents or grandparents had diverticulitis, you're more likely to have it as well. And overuse of NSAIDs and aspirin has been linked to diverticulitis as well. And I think we covered all of them. One that was relatively new for me included the fact that we see left-sided diverticulitis most frequently in North America and Europe, whereas in Asian populations, right-sided diverticulitis is actually much more common than left-sided diverticulitis. And there is no clear reason as to why this would be, but certainly something to keep in mind as you are performing your point-of-care ultrasound to look for diverticulitis. All right, symptoms of diverticulitis can include nausea, fever. Patients may have abdominal pain. Again, could be left lower quadrant, could be right lower quadrant, depending on your patient. Sometimes patients will complain of back pain rather than abdominal pain. They generally still have a pretty good appetite and will be eating despite the pain. And this is different in appendicitis, for example, where patients lose their appetite as the disease progresses. With diverticulitis, most patients actually continue to eat well and have an appetite. So how do we perform this exam? This again is much more similar to our exam for appendicitis. We can use a phased array, a curvilinear, or even a linear probe if a patient is very thin. You want to have a lot of ultrasound gel, And again, you can ask your patient to point to the area of maximal tenderness. So unlike small bowel obstructions, where patients may be very distended and have a hard time pointing to one particular area of pain, diverticulitis and appendicitis tend to cause one particular geographic area of pain which the patient can point to. And that's where you should start ultrasounding. So what are we looking for when we're trying to find diverticulitis on ultrasound? Well, there are a couple of things. The first is we got to find some diverticula. So diverticula are these little outpouchings off the bowel where the bowel wall is weak. They often contain air, but they may contain fecal matter as well. Similar to appendicitis, we're looking for surrounding fat enhancement. So there should be white, bright, hyperechoic fat around that diverticula. You may find diverticula that don't have this, and those are unlikely to be infected or the cause of a patient's diverticulitis. But what you're looking for is not only a diverticulum, but a diverticulum that is surrounded by free fluid or fat stranding. Certainly that area should also be tender with compression. So as you're looking through that area of bowel, you may find multiple other diverticula that likely don't have any fat enhancement and are not tender with compression. So you're looking for the one that does have fat enhancement and is tender when you compress with your ultrasound probe. Here's a nice example. This is a still image of a diverticula. And you can see it up here, we've got our colon and then this little outpouching. These almost look like grape-like structures coming off of the bowel. And here you can see some fat stranding, some bright white hyperechoic fat surrounding that diverticulum. And when we pressed down, this patient was tender in this area, leading us to diagnose diverticulitis. Here's another still image with a curvilinear probe. Again, you have bowel here, and then coming down this grape-like structure of the diverticulum. Again, training your eye to look for this hyperechoic bright fat enhancement or fat stranding, because that's going to point you in the direction of the area of infection. Here's a nice video clip, again taken with a curvilinear probe. And we have the probe marker pointed towards the patient's head. Here again, you can see this loop of bowel, right? Stool filled with maybe a little bit of air as well. And as we scan through the bowel, first you see the fat enhancement and then you see the diverticula coming off the side. So let's watch this again. Here's the fat, and then in the middle of that you see a diverticula that has some stool, some fecal material in it, with posterior shadowing right there. So again, you're training your eye to look for this enhancement, the fat stranding or fat enhancement, which points you in the direction of the area of infection. Here's another nice example. Again, we had the probe marker pointing towards the patient's head. Here we found a loop of bowel. This is the area of maximal tenderness, and we found a very nice looking infected diverticula with surrounding fat enhancement as we scroll through. And then again, we see some posterior shadowing, so fecal material within that small diverticula. So this is an example of diverticulitis. So let's talk about the literature using point-of-care ultrasound to make the diagnosis of diverticulitis. So again, most of this literature actually comes from Europe, where ultrasound is much more prevalent as an imaging modality compared to the United States, where CT imaging is much more likely to be performed if the clinician suspects diverticulitis. So this study, published in 2008 in European Radiology, looked at the diagnostic accuracy of ultrasound versus CT. They looked for studies that had been published between 1966 and 2007. Specifically, they looked for prospective studies of patients with suspected diverticulitis using ultrasound or CT imaging. They found 12 studies that fit the description that they were looking for, with almost 1,200 patients. And what they demonstrated was that there was no statistically significant difference between ultrasound and CT when looking at the sensitivity and specificity to make this diagnosis. So this is huge and demonstrates that ultrasound can not only accurately, but in our case using point of care ultrasound, very quickly make the diagnosis at the patient's bedside, obviating the need for CT imaging and decreasing a patient's length of stay in the emergency department. So certainly there are advantages to CT imaging. Probably most saliently is you will figure out what other disease or pathology may be going on if it isn't diverticulitis. So maybe the patient again has a kidney stone or pyelonephritis or an early small bowel obstruction. But I would argue that you should be able to find any one of those diagnoses using ultrasound. So if you're going to perform a point of care ultrasound and you're looking for diverticulitis but you're not finding it, move on and look for another diagnosis at the bedside to see if you can figure out why the patient has abdominal pain. So another study looking at the benefits of sonography in diagnosing uncomplicated acute diverticulitis, published in the Journal of Ultrasound Medicine in 2015, was a retrospective review of medical records over the course of 2 years, looking at 253 patients with clinical symptoms of diverticulitis. The ultrasound was performed by an emergency physician before the CT scan in all cases. Exclusion criteria included patients who had cancer, who were likely to have other diagnoses. If only one of the two tests were performed, so patients had to have had both an ultrasound and a CT scan as the gold standard. And patients were enrolled in this study, I should say, took place in Santo Domingo in the DR. So the authors wanted to evaluate the radiation and cost of ultrasound versus CT and look at whether ultrasound would potentially be a better imaging modality in an emergency department. So again, patients all underwent a point of care ultrasound followed by a CT scan. Again, there was no statistical difference between ultrasound and CT scan in making this diagnosis. The obvious benefits of ultrasound would include the shortened length of stay in the emergency department, the reduced cost for the patient, and that there was no radiation exposure. And if you think about it, patients with diverticulitis and with kidney stones come in frequently, right, with recurrent symptoms or recurrent kidney stones, recurrent diverticulitis. So they may get many CT scans over the course of their lives. So if there's something that we can do as providers to make the diagnosis without having patients need to undergo radiation exposure, point of care ultrasound is going to be our best bet. So we actually published a case series a couple of years ago now in the World Journal of Emergency Medicine looking at ultrasound diagnosis of diverticulitis. And we looked at multiple patients where we made the diagnosis using point of care ultrasound and then followed up to see how patients were doing. Of the patients that we looked at, 2 of them did very well. They had their ultrasound that diagnosed diverticulitis. They were prescribed antibiotics and they went home. One patient came back a week later with a perforated diverticulitis that needed to be admitted to the hospital for IV antibiotics. So what I would say is that in the stable, non-toxic patient with normal vital signs who present to the emergency department with symptoms concerning for diverticulitis, bedside ultrasound is an excellent first-line imaging modality. CT imaging could be reserved for patients who are toxic appearing with unstable vital signs, who are unlikely going to be able to tolerate oral antibiotics, who may require hospital admission. Those are patients in whom I think you should still do a point of care ultrasound to look for diverticulitis, intra-abdominal free fluid, or another cause for the patient's pain, particularly if they are unstable. But these are patients who will probably also need CT imaging. and hospital admission. So limitations to ultrasound, this is something that we have to be very cognizant of if we're starting to use point-of-care ultrasound in the emergency department on our patients. Certainly one of the most frequently talked about limitations is bowel gas. If you have a patient with a lot of gas, and this is particularly salient in patients in whom you are looking for a AAA, it can be very difficult to find what you're looking for. You can certainly apply firm pressure and see if the bowel peristalsis is out of your way, but do keep in mind that this can be very painful for a patient. Other limitations to ultrasound include the fact that it is operator dependent. This is something that we had talked about a while back. The more ultrasounds you do, the better you get. So I would encourage you all to start scanning as soon as you can to improve not only your agility with ultrasound, but also your ability to make the correct diagnosis. Obesity. Obesity is known to decrease or degrade ultrasound images and can make it harder for you to figure out what's going on. And I'd say finally, really be thoughtful about pain. Patients are in a lot of abdominal pain. Perhaps wait until they've received a dose of pain medication, whether it's Toradol for kidney stones or morphine or Dilaudid if you suspect something such as a small bowel obstruction or appendicitis. Give them some pain medication before you ultrasound them. All right, thank you all very much. I'm so excited that you are here, and I can't wait to start scanning with you in the emergency department.